But my name is Denise Mills, and I'm a nurse practitioner at the Hospital for Sick Children. I work on the solid tumor team, so I look after other patients, not just neuroblastoma patients, but really that's where I gravitate towards the most. It's probably about 90% of my practice. So some of you know me, but I just wanted to say that I think one of the great things about being a nurse and a nurse practitioner is when the doctors get to go back to the lab, I get to go back with you guys. And that's the most important thing to me, and that's what I really enjoy. And I get to come to the bedside. I get to, anyone that has talked to her knows that she comes to the bedside as well. But I get to spend many hours and learn so much from the parents and the patients, and learn what the questions are and what you really want to know and learn about, as well as all the support from the families and the patients. And just look at this group coming together to then add just little bits to the pot to make such a big pot, and look where it's going. And that's just so impressive to see, and I'm so excited to be here today and participate in that. So what I'm going to do is talk to you about MIBG therapy for high-risk neuroblastoma patients at the Hospital for Sick Children. We're very, very excited, and it's just the right button to go to the next slide. Arrow down. This is a Mac, I'm a PC. So neuroblastoma is we're going to be the second center in Canada. There is a center at St. Justine. It's a smaller center, and they can only, and because it's an old room, it was used for iodine therapy however many years ago. They can only do a few patients a year and certain dose levels. So what we first did was we had to prove, and I wasn't involved in this original work because it's been going on for many years, that there was a clinical demand for an MIBG center at the Hospital for Sick Children. There's 50 to 75 Canadian children per year diagnosed with neuroblastoma, and 50% of these have high-risk stage 4 disease. So there's been access to MIBG therapy for Canadian children has been limited because we didn't have a facility. So we have been sending some patients to the United States, and up until recently, the government wasn't covering the costs. So we were able to prove to the Ministry of Health that the projected volumes would support having this program. And also because of philanthropic donations, we will be getting this room built. This is just a map to show you where in North America there are centers. And as you can see, most of it is all concentrated over on the east, and then very little centrally. There might be one or two more stars added. This map's about 2 years old. And then only a few on the west, and I know there's more on the west opening. So indications for MIBG therapy. What patients are going to be getting this therapy? This therapy has been studied the most in relapsed or refractory disease of stage 4 high-risk patients, and it's been studied since the late 80s. So it's not new. It's actually something that's quite old to some people here. The 80s wasn't so long ago for others. And Kate Mathey and her group have been doing numerous clinical trials through the NANT consortium and proving that by itself or in combination with other agents it can be affected. So the largest studies show that MIBG is given as one dose. You may, for those of you that know about MIBG, may know that sometimes it's given in tandem with 2 doses. That 1/3 of the patients have a response, 1/3 will stay stable, and 1/3 will go on to progress. Those are simplified numbers. So what did we have to do to start the planning for the MIBG program at Sick Kids? Well, it involved a heck of a lot of people and a lot of different disciplines and a lot of different departments within the hospital. I've met more people through this planning. Radiation safety, nuclear medicine, nursing educators, social work, a patient navigator, which is a new role to our neuroblastoma new agents and innovative therapy program. Child life has to be involved. And as we go through, you'll understand why it's important to get child life. Camp Ooch is going to be involved with us peripherally. So what is MIBG? Almost all of you have had experience with MIBG. And MIBG is short for meta-iodobenzyl guanidine. I have to practice and practice and practice. And when it's attached to a radioactive iodine, it's chemically attached. It forms 131I-MIBG. It's a clear liquid. It just looks like water, but it's more than water. It's a substance that, when concentrated in neuroblastoma cells, and I'll show you a little bit about how it gets there, can then give internal radiation to these cells and then hopefully target and kill them. Where does it come from? So this is an example of a vial. It's produced by pharmaceutical companies, and actually the MIBG that we'll most likely be getting is produced in Quebec from Draximage. It's shipped frozen to the Hospital for Sick Children, and it will then be brought up to the radiopharmacy to be stored and thawed, because it's shipped frozen. And why is it different from other treatments? Most of you are familiar with chemotherapy, external beam radiation. This has minimal side effects. I'll briefly touch on the side effects, but when you compare it to chemotherapy and say 20 to 24 cycles of cyclophosphamide topotecan, it'll have much fewer side effects. Because hospitals have to control the radiation, and the Canadian Nuclear Safety Commission tells us all our rules and regulations, we've had to provide special training to all of our staff that will be working with these patients, as well as nuclear medicine, radiation safety. And there's been groups of us that have gone on site visits. So I've been to the Children's Hospital in Philadelphia, as well as more recently Boston, Dana-Farber, to see the whole process. And we've gone with our radiation safety officer and nuclear medicine technicians. Yes. Oh, sorry, Sid. I'm sorry, you're out of my periphery here.
Some question they ask astronauts type thing. But anyway, it's going through my mind here. Child's full of beep, 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 131. And child pees, so urine is full of beep, 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 and that's a thing. And you can't just flush a toilet into the system going beep, beep. Where does that toilet flush to?
It flushes into the system. But I will show you.
So we're drinking it.
No, we're not really drinking it, because it does go to, we have sanitation departments that all our fluids go to, but there are many individuals out there in this world that are taking radioactive iodine for other diseases, and they use their washroom. When you with radiation, we'll go a little bit into radiation, you can actually dilute it, and it decays as well over time. So it's got a half-life, and when you dilute it, it gets less and less and less. So we're designing this special, it's not even completely finalized yet, urine system at the hospital where urine will go directly into a drain that has continuously flowing water that goes with it, so that it dilutes it.
I knew that, but I just love that whole thing, and I'd love people to know, why is it so complicated? Because even flushing a toilet is suddenly a really big deal.
Yes. So when you visit the other programs in the United States, they have the urine. So these children, and it's on another slide, these children will have urinary catheters in them that we will put in under sedation, so that it's not a traumatizing procedure, because we also want a urine catheter that's the biggest size, and that will stay in there nicely without bothering them. And these catheters will have the urine, which is the most radioactive body fluid that's going to come out of the patient, go right into our drain. Whereas other centers, they have tubes running across, going into a continuously flushing toilet, or they go into a catheter bag that then the family empties and brings to the toilet and dumps it and flushes it 3 times. So there's some debate over whether to put the Foley in or whether not to, and let the children void on their own every 2 hours. Our decision has been to put the Foley catheter in at this time. After it's been thawed, then the nuclear medicine tech will draw it up behind all this lead. What's great about our room at Sick Kids, which will actually be the first room in North America that has a radiopharmacy within the room. If anyone has been at the Hospital for Sick Children and knows about our room 12, from room 12 is our 4-bed room, and that is now our MIBG suite and is almost upon completion. So my wish as a charge nurse way back when was to blow up that room, and we got to do it finally. I got to see that happen, and there will be, when not used for MIBG therapy, it will actually be used as a 2-patient chemotherapy suite. So this is just showing you what other centers have. There's a cart. The drug has to be lead-lined because it is radioactive. I'm going to talk a bit more about radiation because of the way it emits. And then it'll be wheeled right up to the child and injected via their central line or a peripheral IV, depending on the circumstance. So what's happened, it's injected into the bloodstream, unlike the external beam radiation that the child lays down and then gets the radiation to wherever their tumor will be. And the remaining, whatever goes into the neuroblastoma will go there, and the remaining will be eliminated into the urine over the next several days. Over 50% of it will be over the next 24 hours in that urine will come out.
So will you encourage it to come out faster, like with extra fluids?
Very good question. They'll get 2 times maintenance therapy. So another good reason to have the Foley, because they're going to be needing to pee all the time. So what are the side effects? So some of the side effects can actually make you a little bit nauseous. The children that we have sent, I think only a couple reported back to me that they had nausea, but we will give ondansetron either around the clock or as a bigger dose before giving the MIBG. There can be some hypertension or high blood pressure. And then you can have inflammation of the salivary glands, because that is another place where MIBG will concentrate. And that can hopefully be, that pain can be subsided with Tylenol and or lower doses of morphine.
So the pre-iodine base as well?
Yes, so we'll also give thyroid protectant drugs. That's on the next slide. And they will get, they'll get Lugol solution. They'll get a preloading dose. They'll also get a potassium perchlorate loading dose as well. And then they'll be on Lugols for 6 weeks. Bigger than that 0.25 mils that we prescribe now. So it's going to be around almost a milliliter depending on the size of the child. It'll be daily for that 6 weeks. It's every 6 hours in the first, I think, 48 hours. I don't have the exact schedule.
Just a quick question. I know the answer, but how many injections are you talking about? Just for
Sorry, so the question was how many injections, like how many MIBG injections? It'll be just one. I didn't put anything in my slides about tandem MIBGs or subsequent MIBG doses, because that can happen. But right now our goal is to treat with one treatment, MIBG, in the beginning. So some of the later side effects, and which we definitely see, is myelosuppression or lower white cells and platelets, and we'll give G-CSF for that. So some of the children can be on G-CSF for a month. There's all these different requirements, and if they don't recover, then they may get some stem cells back, which when we collected right up front for the high-risk patients after cycle 2, they collected enough for the high-dose therapy stem cell rescue, as well as for what the future could bring. So then we would...
So there needs to be enough.
There needs to be enough. There are options to still give MIBG therapy if there isn't stem cells, and that could be a lower dose of MIBG. And recovery usually starts between 4 and 6 weeks after the therapy for the counts. There's not often fever neutropenia in there, but that could be a potential. What are the late effects? There's the potential of hypothyroidism. We are giving the thyroid protecting agent of the Lugol solution, and the United States gives something called SSKI. there is a risk of secondary malignancies, such as MDS and AML, which is a type of leukemia. That's approximately 3 to 5%, but that risk is there. It's hard to say if it's the MIBG therapy. So sorry, they're asking, is the secondary malignancies related to the MIBG therapy? And it's hard to know that question exactly, because these patients have received a lot of other therapies up front, as well as the high-dose therapy and stem cell rescue. So we think there is, that it could be the potential risk, but we don't know for sure. When we're bringing this to nursing and the physician group at the Hospital for Sick Children, everyone cares very much about these children, but they also want to know, what will this do to me? It's radiation therapy. And I'm going to talk more about, we're building a room that has lead-lined walls, has lead shields. So there's a potential risk if we're putting all of this into place. So how will this therapy affect caregivers beyond also the children? So the caregivers, including the parents, are going to have to follow very strict guidelines to provide this treatment. Otherwise, we won't be able to do it because it'll limit the radiation exposure for them as well as others. There'll be many safeguards in place. We're going to have protective clothing, which we call PPE. It's very similar to what the nurses wear when they're giving chemotherapy. And staying in this lead-lined room, and I have pictures of all the lead in the room after that I'll show you. And there's going to have to be limited contact with the child, which is going to be one of the hardest things. And I also, as a nurse, I was like, how can we even do this? And I've had patients that have gone and done it, and they really have surprised me. They've done really well with it, and the isolation, because many, even if these children were sleeping in their own bed before they were diagnosed, very often then there becomes a family bed with a sick child. And now how do you go and make this child sleep in a bed with their parents sometimes not even in the room? One of the great things about our room that we're designing is the parent portion is within the room, and you can actually speak. It's not behind a wall and not behind, it's just behind two leaded shielded walls that are only, I think they go up to 4 feet, the second shield, and they will be able to stay in that other side and be able to talk to the child without having to go right over to them and touch them. All of this is regulated by the Canadian Nuclear Safety Commission. And here in Canada, there's a lot stricter guidelines than what's in the United States. So if anyone's talked to families or on blogs, has seen what in the United States, what they went through. There was 1 or 2 shields around the bed. It was a lead-lined room. We are actually going to have shields all the way around the bed. All the walls are lead-lined, and another set of lead-lined shields after the first set of lead-lined shields. So we've had to do a lot of talking with nurses and physicians and how we're going to provide this care, because it's not going to be easy, but I think we're going to be able to do it. I feel pretty confident. I'm just thinking. So is there an age restriction? A very good question. So right now our thought is around 3 and up, but it would have to be on a case-by-case individual basis. And we'll have, so in some of the centers that I've been visiting, they do things like when the patient comes for a consult, especially if they don't know the family, when they come for a consult, they separate the child from the parents. The parents go off and learn about the therapy and do the consult, and the child stays with a child life specialist or a nurse, and they see what that child can manage being away from their family. It's a lot longer than a 1-hour consult, but this is where we're going to have a lot of collaborative discussions with the families and think what their children can do. Like I said, I've seen children now that have done it that I thought there's no way they could stay in that bed. I think the Foley is also something else that helps keep them in the bed when they're the younger.
I'm just thinking,
yeah.
3-year-old, and she's very creative.
Oh yeah. We're also in discussion about using anti-anxiety drugs such as Ativan or Benadryl or Gravol to keep them more of a low key. And we're also in discussion with our pain team and sedation team about giving midazolam as a very low dose infusion. And it's just when it comes to then monitoring children, we're very strict with our monitoring guidelines, and how can we do that when we're not allowed in the room?
Yeah, because usually the nurse has to stay.
Yeah, so we have video that we can see from the nurse's station, so the parents will just always have to remember that. We have video from the nurse's station, as well as there's an ante-room inside that anybody can be in and not be exposed. So we will have lots of different monitoring, and there's monitors we can hook them up to the children, and we'll read out to the nurse's station. So why does the child need to stay in the hospital? And they need to stay in the hospital because the radiation levels that they will be exposing is greater than what you can have when you're out in the general public. So it's dictated by the CNSC of when you have to stay. And it'll be monitored by radiation safety. And when it's at a level that it's safe enough to go out in public, then the child will be able to go home. There'll be special considerations for people traveling from afar and might need to get on a plane to get home, and they might have to stay a little bit longer in the hospital. So there'll be strict discharge guidelines to prevent this radiation exposure at home as well, because they will still be radioactive when they go home.
I know they set up the lamps at the borders as well.
Yes, they do. That has happened. Also, the United States, and I haven't contacted Toronto Waste Management yet, but in the United States, all the garbage trucks have radiation detectors on their trucks. So they've then taken some garbage and have then had to report it to their nuclear safety people, and then people go to the home, knock on your door, I don't know who those people are, and say what's happening with your garbage, but we'll provide letters. And I do know that the border for sure, if that child crosses the border, they will need a letter. It will stop the traffic.
It's a common thing.
It's yeah, adults.
Radioiodine, and then also certain heart tests also make patients
Mm-hmm.
so they're used to it at the hospital.
Yeah, so as long as you have that letter, you're okay. Yes, Indira.
How long does it take for the radiation levels, so for the child to be at the hospital on average? And
So Indira was asking how long will the radiation be detected, and the child will be in hospital from between 3 to 7 days, depending on the average will be 5 days, depending on the levels. And how long the radiation is detected after, it's probably depends on, yeah, because you can set something very sensitive and it'll go off even for someone that's not radioactive, right? So.
And does the boy stay in for 7 days, or there's something that can take it out?
So that's what we're still in discussion. Right now we're going to leave it until discharge. There will be room for amending things as we move forward. In the United States, depends on the program you're in. Most of them keep it until the day of discharge just to make it less, more protection. So just radiation basics. I'm not a nuclear physicist. There is one working on the project, so they've done all these calculations around it. I'm trusting them. He's a very serious guy, so I think he knows what he's talking about. But alpha radiation are particles that move very slow and heavy, and they can't even get through paper. So, but they can't penetrate skin. This isn't what we're talking about. There's beta radiation, and these are particles that move fast and are light, and they can penetrate skin. The beta radiation is a radiation that's actually working on the tumor from within as it decays within the tumor. And gamma radiation, they travel in waves and can travel for many feet in the air and many inches and can get through such as wood, but will be stopped by certain lead thicknesses. Gamma radiation is what the child will then be emitting, and that's what the family caregivers and or the healthcare providers would be exposed to. So will caregivers be exposed to radiation? And the answer is yes, they're going to be exposed to radiation during this treatment. There will be online modules that they'll get to work with before they even come to the hospital for sick children. They will spend lots of time with the physician, the nuclear medicine physician, the radiation safety officer, and myself to get proper training to then reduce the exposure. we will be following the guidelines as outlined by the CNSC. There also will be a parent, or we're calling it family caregiver because it doesn't have to be a parent that comes and stays, agreement that we are working on currently that is going to be an agreement on what work is the family caregiver going to provide and what work is nursing and medicine going to be providing. Because the reality of it is the nursing staff on the ward, who are the ones that will go in the room the most, will be exposed to many children over many years, whereas the parent will, or family caregiver will, it'll just be their child. So a lot of the work that'll be traditionally done by nursing is going to be done by the parent in the room. So it's going to be collaborative. And I didn't bring that agreement yet because it's still going through all the yellow tape. So, but it'll involve all different precautions, and such as who does vital signs, when do they do them, who's going to empty the urine, deal with the urine and the Foley care, which is why we're hoping to have, we're working on the system that nobody will have to empty it, it'll all empty it itself, which we're hoping will work, and that will reduce everybody's exposure. But by following the precautions that we're going to put in place, it'll minimize the risk to all individuals. The agreement will also be that, you know, you don't want to take risks to yourself. We know it's your child, but we also want to protect you. And there's CNSC guidelines that outline how much a family caregiver can be exposed to. So exposure from radiation can be divided into two. There's external radiation and internal radiation exposure. So external radiation is the gamma rays that are being emitted that you can then be exposed to. The interesting thing I also learned about gamma rays is you can actually wash them off. So that's kind of why we wear the gowns to prevent it from touching our skin. But if it does, and we will be wearing gloves, double gloving, if it does touch our skin, it can be washed off as well. Internal radiation is radiation that you might pick up and then contaminate yourself by ingesting it or breathing it in. And that's why the parents, unfortunately, will not be allowed to eat or drink within that room. The child can, but the parents can't. And we're looking at ways where we really want there to be two family caregivers so that they can spell off of each other and someone then can go off to get something to eat or drink. So let's put radiation a little bit into perspective. And I'm going to tell you a little bit about what the typical Canadian receives. So the typical Canadian receives about 213 milligrams per year. There's also the millisieverts beside it. We kind of go back and forth. Right now we're using milligrams, but if you look it up in the literature, you'll see a lot about sieverts. So just living in Toronto, I receive about 159 milligrams of background radiation in a year. If I was to go on a flight across the country, I'm then going to get another 5 milligrams. If I'm going to have a chest x-ray, it's 25 milligrams. And then as you can see, PET scans are 630. An MIBG scan is 780. And a CT chest, abdomen, pelvis is 1200 milligrams. What are we allowed to receive on top of all of this that we naturally give ourselves? And we live, and majority of people are healthy and fine because this is what's in everybody's environments. What a healthcare provider is allowed to then be exposed to is 100 milligrams a year looking after these patients. So this is one of the reasons why we have to be so careful, and with all of our, plus we don't, all the late effects are not well known yet too about exposure. What can a family caregiver be exposed to? It's 500 milligrams. So it's a bit more because it's a family caregiver. They're considered part of the patient unit. And it's just once, whereas the nurses will be in there many times. So what is, so the average dosages that Boston has published, and Boston, that's been on a smaller unit with probably about a quarter of the nursing staff that 8A has at Sick Kids. They're getting around, their nurses are getting around exposure of 50 milligrams per year. That was published earlier when we were recently there. They're getting much, much less than that. They're getting from anywhere from 0 to 23 milligrams in the last year. That's not been published yet because they've just learned so much more. And what they also had in the beginning was, and nurses, this is just the way we as nurses work, they were volunteering to look after these patients because they wanted to. And we always strive for continuity of care. There won't be continuity of care now, and when these children are in the MIBG room, you will have a different nurse every day, every shift, and then we're going to keep track of that. That's to minimize all the exposure. What's another way to minimize exposure? You minimize the time. So time, you need to spend as much time away from your child as possible, or we need to spend as much time away from your child, which is so opposite to how we usually think. But we are stacking this room with, I don't even know what the newest game system is. If Matthew was here, he could tell me. But Minecraft. Yes, Minecraft. Oh no, he did tell me about Minecraft. But there's going to be, I think there's going to be an Xbox. There's going to be video streaming. There's going to be Wi-Fi. We're going to have to be very careful what comes into the room. We're just arguing now about what we'll let people bring in, but we are going to purchase iPads as well that we can have in there for the patients to play on. And if they do get contaminated, we're going to decontaminate them in a lead bunker down in the basement for however long it takes. I've been fighting really hard with radiation safety, and they're like, we don't want to do that. And I'm like, yes, we do. So. Because it's okay to put something in a box and lock it up for 3 months. I'm okay with that. So we're also going to maximize the distance. So room 12, if anyone's been in it before, is a very big room, actually. So we're going to have a lot of physical space. And any mathematicians in here, it's in the inverse square law. See, I knew you would know it. But the further you go back, it squares off your distance. So me just stepping back another foot makes it even further away from the radiation. There's also an anteroom there that the parent can sit in. The parent room is actually, a parent should be able to sit in there and receive no exposure at all. So we're very lucky in that. Other centers, the parent has to stay in the hallway, sleep in the hallway, at the end of the hallway with all the lights and noise. We won't have that. And then stay behind all the lead shields. So there's lead shielding all the way around the bed. And right at the head of the bed, there's going to be a shield that's slanted so you can actually lean on it and protecting yourself more and do whatever needs to be done with the patient. How can you prevent or reduce the risk of exposure to internal? No eating or drinking, wearing gloves, and washing your hands as you're leaving the room. There's going to be this whole procedure of how to put on the PPE that we're called the gowns and gloves, and a whole procedure of how to take them off, because it has to come off in the lead room as you step out. So it's a little bit of a balancing act, but we'll get it all straight. The other thing that will be, and I don't have any pictures of it, with the PPE, there's also going to be dosimeters, and dosimeters are what will measure the radiation exposure and give you an instant reading. It'll be under your clothes, and it'll give you an instant reading as you come out of the room, and it will have logbooks to do that. The nurses will also do that. The nurses are also going to be wearing a badge that gets sent away quarterly to be registered with the National Registry, and that's just an occupational health thing that we have to do. And there's some movement. So we've already touched on the radiation. So 50% of the radiation will be excreted through the urine within the first 24 hours. Most radioactive thing, most hot thing. That even can be dealt with if there was an accidental spill, but we want to for sure not have that if at all possible. So we have this special system that we're designing. And we won't be collecting any samples as well. There won't be samples sent to the lab. There is some evidence that once you get a few days after that you can actually take blood samples if need be. It's a good question. So what if the child vomits? That vomit will also be radioactive, not as radioactive as the urine, but it is. So we're looking into, these, what we call kidney basins, K basins, whatever. I've never loved them. They splash a lot. We're looking into emesis bags, where it's like this little funnel and you can vomit into them, and then it can just be tied up and thrown away. We are going to be asking the families to deal with vomit if they do, and to clean up after it.
Yeah, it struck me as something that definitely be happening.
Yes. Some of the children are nauseous, and when we were in Boston, they said they don't have a lot of vomiting, but it does happen. It does happen. And as we know, like a lot of 3-year-olds don't give us a lot of notice. They just, there it is. Yeah. Often all over everything. You'll hit every corner if possible. So we're going to have to do a lot of education with the kids too, and talking to them about when to use what, if they feel kind of funny, and because you're not sitting beside the bed. You're going to be sitting a good 15 feet away. There'll be a radiation monitor above the head of the bed that's going to give instant readings all day, all night. And this also will be what our radiation safety officer uses for their daily. They have a one-time daily reading at the same time to determine when they can then be discharged from the room. So this is the room in Boston. I don't know if you can, it's kind of hard to see it, but on this bed too, it is all plastic lined. So like I said before, radiation can be wiped away. It can also just be packed up and thrown away. And it won't necessarily, these are the lead shield at Boston, and it then won't go through to the lead shield just with having that plastic, and that's just from touching. If whatever clothing the child is wearing will for sure be contaminated, so we'll provide hospital pajamas, because if you don't want the child to bring their favorite pajamas and then have to throw them away, because that will happen. All the equipment that we use will be plastic. The floor will have plastic on it, as well as it's like paper plastic together. It just makes for an easier cleanup after. The bathroom, as you can see, the sinks are steel. The toilet is actually a steel toilet, and that will be the same with us. We're going to have a steel shower in there as well. We won't let the children shower within the first few days, but before they go home, we'll want them to shower. And that is all been, this is a plasticky tape over it. We don't know if we'll use this substance, but we'll use something. Everything that you could touch will have plastic over it in the room. So what can be brought into the room? Important items need to be left at home, because if the child can't live with it for 3 months, which is potentially how long it could take to decontaminate it, then you don't want to bring it in. That being said, and we're going to be getting iPads, you can cover up a computer and the keys with saran wrap, and then use the keys through the computer, and they shouldn't be contaminated. There's just a small risk. And depending on what the contamination is, it can be sent home with the family, or it might have to be held. And that's where you just don't want something so super important. Our Child Life and Camp Uchagais, as you know, is very involved at the Hospital for Sick Children. We will, in the initial consult, we're going to find out a lot about the child, especially if they're not from sick kids. We're going to find out their likes, and then when they come into that room, it will be set up with new toys, puzzles, crafts, whatever is suited towards them and geared towards them, and that's where Child Life and Uch are going to help us. They can't go in the room while the child's there, but they can do their best to ensure that the child will have everything they need once they get in that room.
So the MIBG in Toronto will be open to other provinces as well. So instead of having to go over the border, we can now go to Toronto. Will it be covered?
Yeah, good question. So the question is, will this MIBG unit be open to the rest of the provinces in Canada? That answer is yes. Will it be covered? We're hoping. It has been covered in different provinces to the United States, BC.
We have gotten coverage using the same forms that we've used in Ontario. So my belief is most provinces will probably cover it for most indications, I think.
Yeah. So we're hoping. And Sick Kids has really been reaching out nationally, internationally, and especially with the neuroblastoma population, we're trying to bring people to Sick Kids if there's protocols that are not available elsewhere, and that's happening. So, and anything disposable, because all those arts and crafts, even if it's a masterpiece, it'll probably have to be thrown out. But the radiation safety officer will come through and screen everything. Actually, the radiation safety officer that we work with, she's actually nuclear tech in our nuclear medicine department. She's amazing and really cares about the kids and wants to make all of this work the best. What can the child do? Because really I've been talking a lot about the healthcare providers and the family care providers. I talked a little bit about that there will be the TVs, movies, the toys, video games, and we talked about the distraction, but they're going to be bored. Like, these kids are, yes, they might have neuroblastoma, but boy, they have much more energy than I will ever have. And they have to stay in the bed, except for potential bowel movements. And we're still working out using a commode versus a bedpan for the first couple days. After the first couple days, we can get them up to the bathroom. We talked a little bit about this. What's the patient caregiver going to do during the treatment? And we want them to give all the medications, give them their food, help them with toileting, vomiting if necessary. And the caregiver, we won't be able to take a patient into that room if the caregiver is not going to be there. So that's going to be very difficult because we're also used to, as nursing, trying to contract to get the caregiver out to have a break. That's not going to happen this time. And that's why we also want 2 caregivers. It doesn't have to be the parents. It can, sometimes children behave much differently with their grandparent or their aunt or their uncle, and actually will do things like stay in the bed much easier with their favorite aunt or their uncle or their friend. But that's also something that we're going to have to talk about as family members and healthcare providers, and because of the radiation exposure. So the caregiver needs to be there, but hopefully not interacting with their child too much and being on their patient's side, and only one caregiver can sleep there overnight. Yes, Indira. So how do we get the food into the room? Yes. So the food will come into the room on disposable trays. And that's another thing. We're trying to get more eco-friendly. This is not eco-friendly. So it's going to come in on disposable trays and be disposed of in there. We're trying to debate how we can do it with maybe the tray just comes to the anteroom and then the parent takes, like the nurse will hold there and the parent will take the food and then hand it to the child. But we're working on all of that. Anything wasted will have to go into a waste bin, and there'll be wet and dry waste, and it will have to be decayed within the hospital basement. Well, no, hopefully the radiation safety officer can take the waste out when it smells, when it's full.
I'm asking because where we have treatment, it's just everything was piled up in the bathtub in the bathroom, so nobody will come and pick it out.
Yeah. So we've had lots of debates about how we're going to do this, but our radiation safety team is okay with coming up. And if the garbage smells or if it's overflowing, they will take it away and put it in our decontamination bunker. And wet waste, for interest because it'll get smelly, we have to put it in a freezer. So we're going to try and, because we just don't want it to be all smelly. I've learned so much through all of this. Just want to be cognizant of time, and it's very close to the time, isn't it? So caregiver restrictions, eating and drinking, radiation safety precautions, protective clothing. We're going to be measuring your doses. You'll have those doses. We're not going to hide them from you. You cannot use the bathroom in the room. That's one of our issues, but we do have other bathrooms available. I talked about monitoring the radiation levels. Dr. Baruchel actually, when he saw this picture, said to me, he said, those are really old monitors. You need new updated monitor pictures, but those aren't old monitors. Those are brand new. So this is what it is, and everyone will be able, and we'll show every parent that. Thank you so much for having us. I really, really, really appreciate it. And if Sid wants to come up.
Thank you very much.